Hello, my name is Sarah Pruitt. I'm the Education Coordinator in Nursing Education here at UMC. Today I'm going to talk to you about sedation. Policy SPP Pound PC 36.1 is our sedation policy. The statement of purpose is to define and describe situations and circumstances when sedative agents may be administered by qualified healthcare providers other than anesthesiologists and to ensure the safety of patients receiving sedative agents in such situations. Identified situations and circumstances include sedation for planned procedures when anesthetic agents, sedation agents, and/or opioids are used pre or intra-procedure. Another identified situation is continuous sedation for intubated and mechanically ventilated patients. Also, sedation, hypnosis for patients requiring emergency artificial airway placement. Moderate sedation is a consented procedure. Palliative sedation is also a situation or circumstance requiring sedation, but I will not cover it during this presentation. For do not resuscitate or allow natural death patients, a DNR or A&D is automatically rescinded during a sedation procedure, as indicated on the sedation procedure consent. So prior to the procedure, nursing will place a white band with ANES written through the DNR armband, signifying that the DNR is rescinded during the procedure. The DNR A&D is automatically reinstated when 20% of baseline PAR scores are achieved post-procedure. A qualified healthcare provider is a physician, nurse practitioner, physician assistant, or CRNA credentialed to provide conscious sedation, or a registered nurse with the appropriate training, skills, and experience to monitor sedated patients, and who is not performing the procedure, with the ability to rescue patients from sedation levels deeper than planned. To administer sedative agents for sedation, qualified healthcare providers must maintain competencies in physiological responses to sedative agents, pharmacologic interactions of sedative agents with other medications, and warnings and contraindications associated with sedative agents administered. There are 4 levels of sedation: analgesia, moderate sedation, deep sedation, and anesthesia. In the next few slides, I will elaborate on each level, and later on I will give examples of medications in each class of drugs approved for each level of sedation. Analgesia, or anesthesiolysis, is used to diminish or eliminate pain and anxiety in a conscious patient. The patient is easily awakened by normal or softly spoken verbal commands and is oriented when awake. All vital signs are stable. There is no significant risk of losing protective reflexes, and the patient is able to maintain pre-procedure mobility. Drugs that are approved for this type of sedation are benzodiazepine, given by mouth or intranasal as a single dose or a single agent. Moderate sedation is a state of depressed level of consciousness in which a patient is able to maintain a patent airway independently and continuously with no interventions or oxygenation required to maintain the airway. Their protective airway reflexes are intact. The patient can be aroused by physical and/or verbal stimuli, for example, telling them to open their eyes. Deep sedation is a controlled state of depressed consciousness or unconsciousness from which the patient is not easily aroused by physical and/or verbal stimuli. Patients undergoing deep sedation have significant risk of partial or complete loss of protective reflexes, including the inability to consistently maintain a patent airway independently, and the inability to respond purposefully to physical stimulation or verbal command. These patients experience a loss of gag reflex, inability to maintain oral secretions, and loss of swallowing reflex may occur. Deep sedation privileges are granted to anesthesiologists, CRNAs, as well as physicians who have completed the ACGME accredited fellowships in adult, neonatal, or pediatric critical care medicine, or ACGME accredited residency program in emergency medicine. Anesthesia consists of general anesthesia and spinal or major regional anesthesia. It does not include local anesthesia. General anesthesia is a drug-induced loss of consciousness during which patients are not arousable, even by painful stimuli. The ability to maintain ventilator function is often impaired. Patients often require assistance in maintaining a patent airway, and positive pressure ventilation may be required because of depressed spontaneous ventilation or drug-induced depression of neuromuscular function. Now we'll discuss what is required prior to the procedure. This is a list of mandatory equipment. Your patient must have an IV access. You must have resuscitation equipment, such as a crash cart, at the bedside. So you will have oxygen, suction, and airway available. The patient must be on a pulse oximeter, and for deep sedation, end-tidal CO2 monitoring is required. Lastly, you want to be sure you have the appropriate reversal agent for the medications that are being administered. You will also need to complete the universal protocol or timeout with everyone in the room who is participating in the procedure. The date, time, procedure, and location will be verified first. Before the timeout, you want to complete the brief on the left-hand side of the form, which includes at least 2 patient identifiers and who verified them. Be sure that all applicable consents have been obtained. Next, the patient's code status and correct site has been verified. During the timeout, you will verify the patient's name, the procedure, consent for procedure, and site or side. You will list who participated in the timeout, and all will print and sign at the end of the form. Regarding MPO status, patients should be MPO or have had nothing by mouth for 2 hours following a clear liquid diet, or at least 6 hours following a full liquid or regular diet prior to the procedure. Keep in mind that all orders may be adjusted per physician orders. When the procedure is to be performed on a child, the provider will discuss the risks, benefits, and alternatives to the sedation plan with the patient and guardian, then proceed with guardian consent. Also, during the pre-procedure phase, you want to review any teaching instructions indicated for the patient post-procedure. That includes any potential side effects of the sedation. Review education and care information with the patient and person who is accompanying them before the procedure. Prior to sedation, you should assess and document the following: level of consciousness, age, and weight in kilograms. Vital signs, which include temperature, blood pressure, pulse, respirations, O2 sats. The provider will assess airway for ease of management and special considerations by utilizing the ASA and Malampati scoring on the sedation form. A baseline physical assessment, allergies, and history will be obtained before moderate or deep sedation induction medications are given. The qualified healthcare provider will reevaluate the patient to determine if he or she remains an appropriate candidate for the use of sedation. Special considerations and precautions for obesity, high-risk OSA, and complex airways. Lastly, you need to be sure that an informed consent has been obtained. The sedation record is where all of that information will be documented, and this is what it looks like. No sedation medication will be administered prior to the provider's section being completed. This is where the physician documents the baseline physical assessment and ASA and airway scores. All medications and or IV fluids administered during the procedure shall be documented on the sedation record. The sedation record serves as the physician order sheet and does not need to be reordered or entered in the patient's electronic record. But the provider must sign the sedation record, or it will appear that you gave medications without an order. The most important thing about the sedation record is that every item be addressed. Do not leave any blanks. During the procedure, you should have a qualified healthcare provider other than the practitioner performing the procedure present to monitor the patient throughout the procedure. Continuous monitoring will be done with documentation at a minimum of every 15 minutes for moderate sedation and every 5 minutes for deep sedation. Documentation consists of pulse, respiratory rate, blood pressure, responsiveness of the patient or level of consciousness, pulse oximetry, and pain score. Additional monitoring like end-tidal CO2 will be required for deep sedation. You should have sufficient personnel present to respond to changes in patient status and initiate emergency interventions if necessary. The person monitoring the sedation cannot be the same person who performs the procedure unless the procedure itself is that of sedation. For example, an MRI with sedation. The patient should also be monitored for potential adverse reactions to the medications being administered. Notify the physician performing or supervising the procedure of any changes in condition. Patients receiving moderate and deep sedation are transferred if needed to an appropriate area for recovery and monitored every 15 minutes until vital signs are stable and within his or her normal range. Nausea and vomiting, dizziness are minimal, and there is no apparent post-procedure complication. PARS score is within 20% of pre-sedation levels and pain levels less than 4 or baseline. Patients receiving deep sedation will be recovered in labor and delivery, cardiac catheterization laboratory, the endoscopy center, the post-anesthesia care unit, the Southwest Cancer Treatment and Research Center, an emergency center, radiology, cardiac outpatient services, or any intensive care unit. The patient requires transportation during this time. A qualified healthcare provider will accompany them. LVNs may assume monitoring of post-procedural patients when patients can be aroused and patients' vital signs have returned to 20% of baseline. Outpatients should meet the following criteria before discharge: vital signs and PARS score at 20% of pre-sedation level. They're alert or easily aroused and responsive to verbal or light tactile stimuli. They have regained muscle control. There is minimal nausea, vomiting, or dizziness, and must be accompanied at discharge. Continuous sedation and control of stress responses for intubated, mechanically ventilated patients in the ICU. In this setting, IV sedative agents should be administered only by qualified healthcare providers skilled in the medical management of critically ill patients and trained in cardiovascular resuscitation and airway management. Sedative agents recommended for this purpose by the Department of Anesthesiology include, but are not limited to, the following: propofol, lorazepam, fentanyl, Versed, etomidate, and Precedex, and the anesthetic gas nitrous oxide. The Department of Anesthesiology further recommends the implementation of approved ICU sedation orders to ensure that titration parameters only be determined and ordered by a physician and should not be exceeded without a physician's order. It is also recommended that intubated patients who require additional dosing of these agents because of bedside procedures must be appropriately monitored every 15 minutes. Continuous sedation and control of stress responses for non-intubated mechanically ventilated patients in the ICU. In this situation, Precedex may be administered in an ICU only by ICU nurses who are trained in the use of the continuous drip, but they are only allowed to titrate the drip down. If it needs to be increased, there needs to be a specific physician's order. The ICU nurses will assess the patient every 4 hours and when the Precedex rate changes using the comfort scale or RAS. Precedex can only be administered by IV pump, and the provider ordering the IV infusion must be present at initiation and be available for 15 minutes after. In the case where a patient needs anesthesia for the placement of an emergent artificial airway or rapid sequence induction, patients may receive an agent for sedation or hypnosis as part of a sequence of medications given to facilitate successful and humane placement of an artificial airway for mechanical ventilation. They must be administered by qualified healthcare providers when ordered by a physician physically present and appropriately prepared to manage the patient's airway. Etomidate is an example of an agent that is frequently used for this. Now we'll quickly go over some procedural sedation medications. The effect that benzodiazepines have is anxiolysis, sedation, and amnesia. A benzodiazepine at a reduced dosage may be combined with an opioid for painful procedures. Be aware that benzodiazepines may cause respiratory and cardiovascular depression, ataxia, dizziness, hypotension, bradycardia, blurred vision, and paradoxical agitation. The reversal agent for benzodiazepines is romazicon, and these are the recommended doses. Opioid narcotics include morphine, fentanyl, and meperidine. These agents can make the elderly more susceptible to CNS depression In fact, meperidine is not recommended in the elderly at all. We need to remember that if you are going to combine opioid narcotics with benzodiazepines, doses for both should be reduced initially until you know how your patient is going to react. With opioid narcotics, you may also see hypotension, bradycardia, respiratory depression, nausea, vomiting, constipation, biliary spasm, and skin rash. The reversal agent for opioid narcotics is Narcan, and these are the recommended doses. Take note that administering Narcan can result in a large surge in sympathetic tone and hypertension in some cases. So monitor your patient closely and be sure to document that you administered the Narcan, or any reversal agent for that matter, and why you had to administer it. General anesthetics include propofol, ketamine, and etomidate. Each agent has its own possible side effects. Propofol can cause hypotension, arrhythmias, allergic reaction in patients with egg allergy, while ketamine can cause hallucinations, delirium, hypertension, and tachycardia. Etomidate causes transient skeletal movements, vomiting, and hiccups. There is no reversal agent for general anesthetics. The pharmacologic effects are not reversible. That concludes my sedation presentation. If you have any questions, please feel free to call or email me. Here is my contact information, and thank you for your time.